1, 2, 3, test. I got it. All right, home stretch before the break. Let's talk about female hair loss. The thing I want to start with is this is actually an advanced topic. It is advanced because it's medically advanced and it's surgically advanced. There's so much more things to think about when you're dealing with a woman than you are with a male. One of the classifications that makes it easy for me is to divide it into unstable and stable. If it's unstable, I don't want to obviously operate on it, but I want to figure out how I can slow it down. When it's stable, then I've got some options. It could be medical, it could be surgical, but the key thing is you want to be a sleuth. You want to sit there and actually take a very, very detailed history, physical, chemical profile, and at times biopsy if necessary, and we'll talk about those incidences. With history, you know, if they had a recent pregnancy where the estrogen kept the follicles intact for a while, and then all of a sudden when they gave birth it shed, that's one of the most obvious things that could occur, but there can be other things that can cause a loss that I usually investigate besides just looking at general female hair loss. These incidences could be an indication of something called telogen effluvium, where it is a temporary phenomenon occurring about 6 weeks to 3 months following either a significant weight loss, general anesthesia, significant febrile issue, something along those lines. Or other comments would be trauma, especially in African American hairs, or ones that have been over-processed, those kind of damages that may not be as prevalent in men. But besides those comments, in general, when I'm looking at a woman, I'm looking at a lot of factors. I'm looking at how long the chronicity of this issue is. If it's a gradual process, then I also want to just do some more investigative work looking at basic laboratory values, which we'll talk about in a moment. And so I always have a very low threshold to bring in endocrinologist, OBGYN, dermatologist as needed. So that thorough history is so important. And I say 30% of women over the age of 30 lose hair. So this is not something uncommon. So you want to make the woman feel that this is actually something quite common, so they don't feel like they're the only one suffering from this, which can oftentimes be the way they feel. The physical exam is very, very important, obviously, when you're looking very carefully. And to make it easy, I divide it into two, which is patchy versus pattern. You heard this from me a little bit yesterday, so it's always redundancy is good. So what does patchy mean? It just means something that looks isolated. There's a area that's missing, and of course, if you see something circular, what do you guys think this is? Can't hear too well, but alopecia areata. And that's something that you want to be careful of. There can be different types of a scarring alopecia, and you're going to hear this lecture later today. And this is something that looks like just maybe a female pattern hair loss. And over the last 20 years, there's been a higher incidence of something called frontal fibrosing alopecia, which on histologic evaluation can be sometimes quite difficult to distinguish from other types of scarring hair losses, but you can see it clinically because their skin starts to change here, their eyebrows may be gone or thinning, they may have more telangiectasias, the pores may start to be gone. If there's something that looks suspicious, have a low threshold to go to biopsy. And so when I start seeing anterior hair loss, and I really do look for this. You know, don't just assume that it's either traction loss or that it's just female pattern loss or male pattern loss. I'm really looking at the skin, and I have a very low threshold to bring a dermatologist involved to do some biopsies. And you already heard a great lecture on, several lectures so far also on African American. I just reiterate this, is that I'm very, very worried about central centrifugal cicatricial alopecia, or CCCA. Anytime I see any crown loss in a male or female, I immediately red flag to look for loss of ostia, look for some unusual pattern. And even if they've got something that looks like a traction loss in the front, I have a very low threshold to biopsy. There's something called a fringe sign, which means there's some residual hair that's there that may indicate it's traction loss. Even with a very clear, convincing history it's traction loss, if I see something here, there's actually a high incidence that it could be involved in the front. So I have them biopsy the active areas in the front and back, and I sometimes guide the dermatologist. Not to say the dermatologist won't know that. And you know, other types of things that can look odd, just doesn't look right. This is like a lichen planopilaris. There's so many things that you've just got to be very, very cautious before you just assume that it's female or male pattern baldness. Pattern losses come in a couple flavors. One is this idea of the Ludwick Classification, which essentially means that there's progressive global thinning with or without sparing of the frontal hairline. So when you see this, a huge part is you say, well, okay, well, we got to look at medical evaluation, but we also have to look at, is this even possibly a surgical candidate? It's the ratio of the degree of loss in the back versus what is available what is the degree of loss on the top and what is available on the back to transplant. It's a ratio of donor to recipient. And so we have strategies to surgically manage this, and we'll talk about that in just a minute. So other types of pattern loss, Lisa Olson talks about this Christmas tree. I like to really comb women's hair patterns into the midline so I can see what's going on. The Christmas tree, the base is in the front, and again, it's with or without involvement of the hairline. Male pattern baldness, there's different hormones that are involved. So in most women, again, I have a low threshold to really do a full evaluation. I just don't assume, oh, it's fine, because they can be optimized if not evaluated thoroughly. And I actually, beyond just sending them to a standard Occidental doctor who's looking for these numbers, I oftentimes will elicit the help of someone who's doing what's called functional medicine, who's trying to optimize those numbers. Not just saying, okay, the thyroid levels are normal, okay, you don't have lupus, your iron is fine, but really trying to optimize those levels. And sometimes that can actually be very, very helpful. So, you know, a summary here is I'm looking at unstable versus stable, patchy versus patterned, and these categories are only meant to help you sort of bracket your thinking and probably approach the patient a little bit more easily. So there are different types of therapies out there that can help women. You don't just jump to surgery. Replacement medications, in other words, some kind of hormonal therapies, thyroid management, etc. Viviscal, I use this personally for women that are it's good for women in general. I like to use it if someone is actively shedding and they need something to control that. If they have an allergy to shellfish, you have to be careful. Low-level laser therapy is very effective, as well as minoxidil. And some of the new thinking is that 94-95% of female hair loss has an inflammatory component. So I like having some kind of compounded low-dose steroid in there to help them, which I don't find to be as critical for men. I don't do spironolactone because I am worried about laboratory values and things like that. I do send it out for dermatologists to have sort of a standard letter to help. I do give finasteride, and as you heard from Mina, I don't give 1 milligram because it's really not very effective, but I've seen efficacy at 2.5 and beyond. Of course, as everyone knows, it is teratogenic, so you do not want to give it to someone who is still having menses. Or has potential for childbirth. And so there's this triad of sort of things that you can do to help. In my first volume, Nicole Rogers here, I have given her full credit for all her help with understanding spironolactone and using her information for volume 1. This is an African-American lady that really was refractory toward standard minoxidil. I used compounded version and she started responding extremely well. The thing that you want to watch out for in women is the risk of shock loss. This is my patient. I fortunately haven't seen this for a long time, but extreme donor shock and shock in the front. So reducing epinephrine, being very careful not to dense pack, and some things we'll talk about in a minute here, can be very helpful so that you don't get in a situation of fear. And really preparing women. I think every woman having surgery will have some level of shedding, and you've got to A, minimize it, and B, prep them. I always say the difference between an education and an excuse. An education is told before and excuses afterwards. So I try to give a lot of education. So before, doing at least 6 weeks of minoxidil, maybe doing some laser in addition, but at least for me the baseline is I want them to be on a 6 weeks of minoxidil therapy, whether it's 5 or 2%, I prefer 5. And really education. During the procedure, I mentioned before, reducing the epinephrine load. If you want to know what that is, it's in the book, but I can send you that information as well. Towel clamp, just not really squeezing down too much on the backside, being careful of over-tumescing, especially the recipient area, and overly dense packing can be very difficult for women to handle. Afterwards, continuing minoxidil, laser. And I tell every female during the consultation, be prepared that you may need some topical therapies, or in the very worst case scenario, some kind of wig or something. Now, the odds of needing a wig are very low, but I just say it so that in case that rare chance that they need to use it for a little while, that they will have the right expectations. So indications for surgery would be a stable patterned hair loss, not an unstable or a patchy hair loss that would be dangerous. So for me, I divide it into really two types. One is going to be just general global thinning versus maybe someone that just wants their hairline to be a little bit lowered, either due to congenitally higher hairline, hair loss B, or maybe brow lifting and things like face lifting that have destroyed that. The safe donor area can be more restricted in women because in the outer areas there can be so much temporal hair loss that you can't go that wide. So strategy is so important when you're working with a woman. So this is something I've written in my book, which is thinking about not just globally filling everything, because oftentimes you're not going to get that greater result. So what I tell women is think about either doing a T or one of these L's. So she said, well, I like to have my hairstyle any way I want. You've got sometimes to pick a hairstyle and design that hairstyle. So what that vertical limb is where the hair is parted. And so this is something that can help you is give patients realistic expectations, tell them it may take 2 surgeries, and look at where they can maximize the effect. If you spread grafts everywhere, they may not get much impact. And so also look at the caliber of the hair, the quality. If they just have really poor donor hair, A, maybe just don't do the surgery, or B, really limit the area you're transplanting. Another thing I've talked about is a dumbbell design, which essentially means that a lot of women have these small crown loss. Some have a more global thinning, but they just don't like how they've lost that shape on a lateral view. We'll talk more about that in our next lecture about crown loss. You understand the lateral perspective of crown loss. And this is a design that I oftentimes do as well. Look at non-balding scalps to really create beautiful female hairlines. And so, again, this is advanced topics, and there's so much variation in them. So when you look at a male recipient design, as I was encouraging, most of the time it's going to be straightforward. Sometimes it's going to be a little different, but for women, there's a little more curvature. And again, another example of a male hairline, and then an example of a female hairline. I'm not going to get into all the details of how to design a female hairline. We can do that in lab. There is a lab section that we can talk about it. But it is something that it is a much more complicated, more advanced topic. And this is just showing you some global thinning and doing more of that dumbbell design. These are just some examples of female transplants I've done. That was a female hairline lowering. This is male pattern baldness. This is someone that was on anabolic steroids, losing that. This is just a male pattern frontal temporal recession. This is just a part and zone. This is African American traction hair loss, transgender, eyebrow, global Ludwig, a little less advanced Ludwig pattern, and a Christmas tree pattern you saw earlier. So we'll go to the next talk.